Thank you all for being here today. Thanks to those who are streaming online. I'm Paul Meyer, the CEO of Smart Health Network. Excited that you're all here, so interested in plumbing, because we're going to be talking about plumbing today. It's a very exciting topic. Our topic today is the health infrastructure for the AI era. I'm actually going to start by reading a little bit of an article that was published on November 25th in China Daily, entitled "Nation Aims for AI-Fueled Healthcare." China has unveiled a plan to integrate artificial intelligence across its healthcare system over the next 5 years. According to the plan, China will have established a robust foundation of high-quality, reliable healthcare data sets and trusted data spaces. The country plans to create specialized, disease-specific AI models and applications to achieve widespread adoption of AI-assisted primary care, intelligent clinical decision support systems, and smart patient services across medical institutions. By 2030, the goal is to have fully integrated AI-assisted diagnostic tools in primary care facilities, while all secondary and higher-level hospitals will routinely employ AI technologies for tasks such as medical imaging analysis and decision support. Meanwhile, our US healthcare system still sends 9 billion faxes a year. So obviously, I think we've all read and heard about the promise of AI. Peter Lee, my colleague, wrote a book 3 years ago about the promise of AI in healthcare, and he'll share some of the exciting potential. We're going to be talking today about the fact that unless we solve some of our core data plumbing issues, we don't get to have that future. China has a clear path, which starts with centralization and aggregation of data to do all the things that this article talks about. The question is how this fragmented healthcare ecosystem in the US and other places can actually step up. A couple of weeks ago, 2 weeks ago, I think on January 7th, we had an exciting announcement from an OpenAI launching ChatGPT Health. Anthropic launched their health initiative. Both very exciting, the premise being get people to connect their data, share it with an AI health assistant. Really exciting if people can actually get their data, which we'll be talking about. Not long after, there was a lawsuit filed by Epic and 4 hospital systems challenging data access to clinical data for allegedly nefarious purposes using these APIs that have been promulgated to allow access. So we have this sort of impasse between the promise of AI and the desire and need to aggregate data and the challenge of how to access it from kind of our existing infrastructure. So that's sort of the topic we're going to be talking about today. Pass it off to Peter. And Peter, why don't you kind of first introduce yourself and then talk a little bit about sort of the promise and excitement you see.
Sure. It's really great to be here. And also, it seems like we connect the most when we're here in Davos, which is, I don't know what to make of that, but it's great.
Well, Peter and I were last together here in the Davos Super Spreader event, which was January of 2020, when we didn't know that we were vectors bringing disease back to our respective home countries.
Yeah, so on the promise of AI, I was reflecting on this. I am the president of Microsoft Research, and so I have the great privilege of leading the research division of our company, and it's a wonderful place. One of the things that I find most optimistic is that generative AI is allowing new superpowers to derive structure from large amounts of largely unstructured clinical data. And there is great work that I'm stupendously impressed with going on at dozens of labs around the world. But if I could just focus a little selfishly on Microsoft Research, there's led by Hoifeng Poon, who's sitting in the front here, is our joint work with Epic on the Curiosity Foundation model, trained on Epic's Cosmos database. And while the foundation model training is very difficult and impressive on its own, what is more fundamentally important is the underlying AI-powered medical abstraction that's able to read these very messy clinical records and derive appropriate structure. And that idea now has been used in many other places. And in fact, Hoifeng put the universal medical abstraction powered by GPT-5 as open source. So many, many people are using it. And I think that's a watershed moment that, from an AI perspective, Paul, eliminates one of the blockers. The fact that clinical data has been so messy and unstructured, I think AI is finally allowing us the real ability at scale to overcome that. There are still other blockers that we're going to get into, but at least that much, I think, gives us as technologists incredible optimism.
Picking up on that point, how do you think about, I mean, there's data in an EHR, which is generally what was captured in the very occasional moments we're in a doctor in a hospital. Most of life is outside of a hospital. So the other thing, of course, AI can do is make sense of lots of different kinds of data sets. Can you talk a little bit more about this sort of the need to bring together multiple kinds of data types and the potential, right? To sort of, I'm wearing an Oura ring. There are all sorts of, genomic data, brain data, all sorts of new kind of data types that we traditionally haven't thought about, doing research on or, kind of incorporating into our clinical decision support.
Right. And so it's actually much worse. If there's one thing I would say over my past 10 years at this, is it's been a long series of humbling experiences. So you're right, even in something like Cosmos, you don't have image data, you don't have genetic data. By the way, you don't have an apparent understanding which of these records came out of a fee-for-service versus value-based institution, because the records look different in those cases. Rural clinical records look different than urban clinical records. There are just huge differences even apart from that, and then there's the whole consumer space. What leaves me continue to be optimistic is that one of the things about frontier foundation models is that if you apply enough compute and enough data, and you continue to see pristine loss curves, consistently in frontier scale model training, you get the emergence of unexpected, unplanned capabilities, and you get much higher degrees of generalization. And so while it is a problem that we still have to increase the diversity in the types of data in these foundation models, once you get to a certain level of scale, the ability to integrate more and more of those modalities actually becomes easier and easier. So I painted a very rosy picture about what AI can do, and it's all the truth. But it all depends on access to data. If you don't have access to data, then it's all theoretical. And so we all know that there's a data problem. And so how do we get over that? And this National Academy study did something very interesting, is it tried to compare health data infrastructure as an industry to other regulated industries that have undergone digital transformation. And so that includes the finance industry, global telecom, electricity distribution, and home construction. So now compare that to what we have in health data infrastructure today. Every system is largely bespoke. I mean, there's a joke, if you've seen one health data infrastructure, you've seen one. I had learned that Stanford Radiology, across all from Stanford Pathology, their IT systems don't talk to each other. It all comes from a good place. Everyone's trying to do the right thing. But without any architectural building blocks, it's tough.
Well, before we go to Chris, just on the architecture point, I like to explain to people, why do we send 9 billion faxes in American healthcare and waste $1.5 trillion in admin expense? Because we built one system for clinical data, electronic health records and health information exchanges, a whole other system for payments and eligibility using an old 40-year-old EDI transaction standard. Those two systems don't talk to each other, which leads to, hey, Dr. Weinstein, we'd love to approve your prior auth. Can you fax us the clinical notes? And that happens about 9 billion times a year, which costs about $1.5 trillion. And meanwhile, we the patients, we the people, like, we weren't invited to either party, right? So this is, American healthcare lack of data infrastructure. Chris, let me pass it to you and ask, first introduce yourself and talk a little bit about the All of Us platform and some of the lessons that you've learned in trying to build that.
And one quick fact before I do, because last year I learned that there are more people doing health administration than doing healthcare providing.
Right.
And that's
What's
an
wrong with this
indication
picture?
that there's something wrong there, yeah. So, hi, I'm Chris Lunt, and I have a quick disclaimer that I'm not here in my official capacity. This is, my opinions don't necessarily represent the opinions of the National Institutes of Health, but I'm the Chief Technology Officer for the All of Us Research Program. And this is an effort that goes back to 2002 when the US first sequences the genome. And to a degree now, for every human being, we can put this book that has someone's genome in it, and we don't know how to read it. We knew the only way we were going to learn how to read that is if we could collect enough information about people's experienced health, what they actually lived as health, and then compare that in a really large way to what we saw in those genomes. We're at a point now where we have about 500,000 whole genome sequences that are available, but in the time of building this up, recognize like it's not only that, we have other new things that are coming in like proteomics and transcriptomics and other things that we also need to learn how to read. And so this program was set up to go out to 1 million Americans and to have them volunteer to join, where we collect a blood sample, that we do the whole genome sequence and other work, we collect their clinical data, we have them fill out surveys, we get their wearable data, and we're adding more and more things so that we can build all the different factors that feed into the experience that you have in health, so that we can understand how that contributes into what are the right interventions to do, both from the perspective of keeping people healthy before they get sick and then treating them once they are sick. The program's, like I say, we're doing very well. We, at this point, have more than 20,000 researchers using the data. We have more than 1,000 scientific papers that have come out of it. And when I first started, I sort of said, what's my job here and when am I done? And I thought, the day the first paper comes out and there's new science, I can be like, okay, I got the pipeline set up, science is coming out. And so we reached that day in 2022, and I thought, okay, so what am I going to do now? Am I going to re-up and stay here or do something else? And if I'm here to re-up, what is it I'm doing now? And the time from a paper coming out that gives something new understanding about health to the time that that goes into practice right now is about 17 years. And I thought, that's something that seems a little ridiculous, and we should shorten that. And as we worked on this project, we would sequence someone's genome, and we would find things in there that were directly addressable. Someone had a monogenetic disease, someone could say, like, you are going to have a problem because of this. And we thought, like, it feels unethical to not reach back to people and tell them, like, there's something you should go address in terms of your health. But there's all these walls that we've built between research and care that largely prevents that from happening. And so we've been a long time with the FDA to try and say, like, hey, can we contact people? We have a very limited set of cases where we can do that are very well proved out. And this feeling sometimes uncomfortably that you see things in the data that you're like, the person should know this, and it's their data. And trying to understand, like, how can we change that? How can we create a better flow from the point of research into actually improving care?
Well, let's build on a little bit. I mean, research traditionally has aggregated big data sets, all de-identified, right? So that we can actually use them for research. But there's been this, separation between research and kind of clinical practice, right? Because it's de-identified. To your point, you have amazing breakthroughs, and then it's 17 years later. As we think about AI now, right, people are excited about how do we aggregate data for training models, which is great. That's the first step. But at some point, the point of having an amazing ChatGPT health advisor is to help me. And I need to then benefit from that. So I'd love for you to sort of draw on that, parallel a little bit, and the structural challenges with how we've approached aggregation of data sets for research purposes and the separation from clinical care, and how do we ensure that we don't make the same mistake where we have aggregation of data for training models, but literally that can't then extend into inference and actually delivering value for people.
Yeah, and it's a lot of it's the fragmentation that we've talked about, that all this data gets collected in these silos, and it's different data types in different silos, and people are trying to connect all the dots between all of them, and it feels like the natural place and the only place you can do this is with the person themselves. And when that person also then is able to contribute the other important data that you're often missing this of what they are actually experiencing in terms of their health, and getting their interpretation of that experience, their explanation of it. I think one of the things for me on the science end of things that's challenging, and what's so exciting about the fact that we have these large language models now that can make sense of doctors' notes and other data that was qualitative and that was hard to bring into these models in the past, is now you're really able to start to fold that in to the point where I no longer want from the hospital your diagnosis. I want the conversation that you had with the patient that led to that diagnosis. Because a diagnosis is a collapse of information. And it's often a collapse of information that discounts the fact someone gave a list of like, I'm having this problem, this problem, this problem, and I had a rash. And they go, okay, well, the rash thing I don't understand, but I know all these other things means that it's this. And what we aren't figuring out is like, no, it actually isn't that, it's something else. Or there's a way we can actually separate what looks like one disease is actually two different diseases. And so if you look at even something like type 2 diabetes, right, which we sort of, we can talk about type 1 and type 2, but there's also really kind of like type 3 and type 4, these different mechanisms these diseases happen through, and then different interventions that are the right intervention, and that we collapse so much of the information by the time we're feeding it into the training model, we've lost the opportunity to improve care.
So Chris, last week, OpenAI launched ChatGPT Health, Anthropic launched their health initiative, both relying on patient access, right? We, in the US, have legally been entitled to get a copy of our health data since HIPAA passed in 1996, 30 years ago. I don't know how it's going for you all, but it's been tough for me. You've been trying to leverage that tool of patient-consented access to aggregate data, which is sort of the bet that those companies are betting on. How easy has it been to actually use patient access as a mechanism for aggregating data, and what lessons have you taken away from your experiences?
I don't think Peter exactly called it a series of humiliations, but that was sort of my experience of every great idea, every attempt to go out there and doing it, and running to all of the misaligned incentives in the system, and that all these people hoarding data because they have the sense that it's valuable, but no capacity to actually extract any value from that, because there's no market that this stuff is really able to move in, and then where it is happening against the consent of the people whose data it actually is.
Oh, you mean when I took my son to the emergency room in the middle of the night and signed some form that wasn't consent to use that data for God knows what 10 years later?
There's certainly been a lot of brokers out there right now who are buying and selling data where people have no idea that that's happening, including in the health space.
Stuart, let's go to you. Peter talked about this forthcoming Institute of Medicine paper about the need for infrastructure and industry to come together to build common infrastructure. You have a little experience and a lot of scars to share. Do you want to share a little bit about the kind of Aavaneer experience and lessons learned?
Yeah, thanks. And I feel like I'm bringing up the rear here with the core message. The core message is there's no solid infrastructure and mechanism for these large language models or for these scientific research studies or care interventions to actually access all of the patient data that's needed. That does require a new infrastructure, and I've been working at that. So I'm the CEO of a company called Aavaneer Health in the US that was brought together by 5 large industry participants, 3 large insurance companies, 2 large academic and large medical institutions. And what we found is that if you can actually connect the systems, the technology is fairly trivial, right? Not trivial in the sense that it's easy to implement. AI is making that easier. Interpretation of unstructured notes, et cetera, will all help solve that. But just getting access to the system without asking a patient to go to the basement of a hospital to get a CD-ROM of an MRI so that they can go get a second opinion, actual system-to-system connectivity has not scaled in our country because we've upgraded EHRs and we've not really focused at all on the infrastructure. And I think this is a global problem, certainly very, very relevant to most of the folks here in USA House. I'm sure everyone's received surprise bills and we all want to take care of that, but without better data flow, that's not possible. What we found is that once you build that basic connectivity with just things like identity resolution and coverage and eligibility information, you can save the industry $15 billion a year, right? With a solution that probably cost $75 million to build and operate, right? Massive ROI. The problem is getting that ROI to scale across an entire ecosystem that's built the spider web of one-to-one, point-to-point connections and are heavily reliant upon some really antiquated infrastructure that sits between them. We all saw in the US a couple years ago a massive data outage that drove physician practices out of business because they couldn't submit claims. Very basic switchboard type connectivity that just doesn't exist. And what we found is we could solve that, but we really needed a neutral, scalable, well-governed, self-governing model to solve that problem at scale. right? Because the business I was running was founded by these 5 large companies. They all own part of it. They all have maligned incentives, as you alluded to, Chris. They also have conflicts of interest amongst themselves, just as competing payers in the same industry. So without really solving the infrastructural governance issue, we couldn't really scale the tech solution that we knew how to build and built at scale.
So one of the things that we've talked about is the analogy to Visa, right? I don't know if anyone's ever listened to. There's a great the Acquired podcast, which is probably my favorite podcast. They go, if you have 5 or 6 hours to spare, they go to deep dives into Microsoft, into Epic, into all sorts of businesses. But one of the great ones was Visa, and Visa was started in Fresno, California in the late 50s as the Bank AmeriCard, and it was pretty successful, and they then sort of tried to propagate it to other banks, and shockingly, it turned out that Citibank wasn't too keen on issuing the Bank AmeriCard. Who could have predicted?
Who'd have thunk?
But the real innovation of Visa was governance. They said, hey, this has got to be, if we're going to get everybody on board, this needs to be governed as a common utility. They brought the banks into the governance structure, so for 50 years, it really effectively ran as a de facto kind of cooperative. So you had 5 owners,
Yep.
all big names. Well, CVS, Anthem, HCSC, Cleveland Clinic, and so forth. And surprisingly, was United Healthcare and Cigna ready to get on board with the CVS Anthem thing?
They were not, right? And I spent the prior 20 years of my career in the banking sector trying to solve this problem for healthcare. So Visa was one of my very first reference points in healthcare processing. And they were not willing to jump right into that.
Yeah. The other thing, Peter, you were talking about this, and this crazy fragmentation mess. My analogy, having been in the space for way too long, is every institution of healthcare, these bespoke systems, it's not just that you have bespoke systems, then they all try to figure out how to talk to each other.
Right.
And every bespoke system tries to figure out how to talk to every other bespoke system for every different purpose in a different way. And so in my analogy is every institution in healthcare builds a different dirt road for every different type of car. Like here's the Ford Taurus dirt road, here's the Toyota Camry dirt road and the light truck dirt road. But going back to this infrastructure, you build one highway and then people can send all the cars down the same highway. So I think conceptually, again, going back to the Visa analogy,
infrastructure.
Think about the Visa. Visa connected 3 parties: a consumer, a bank, and a merchant. And then everybody connected once and reached everybody else. Well, in healthcare, we have a patient, a payer, and a provider. So bring people together to connect once, and then all of a sudden you can have one highway that can support a lot of these use cases. Peter, I'd love to sort of kind of go back to you and sort of, you're obviously deeply both at Microsoft, but just in the industry in general. Like, what are your thoughts on how to kind of overcome this logjam?
Lacking some sort of coherent architectural concept in a mature industry, roughly speaking, to get stuff done in a reasonable time frame, everyone is left to try to do it all on their own. And we just get more and more of this complexity. So I think part of what needs to happen is to get the industry to step back and think in architectural terms, understand that a rising tide lifts all boats, and then move from there. Yep.
We have just a minute or so left. Quick final parting thoughts. Chris, why don't I ask you if any parting comments or thoughts?
I would lean in on what Peter had pointed out, go back into that rosy future that's out there. I think we all recognize, everybody in this room has probably either gone through a diagnostic journey that's been really unsatisfying or is close to somebody who spent years trying to figure out something that was going on from a health perspective. And that we're entering a time where I think we are going to be able to address disease in a way that we've never been able to do before, to integrate all this data coming from all these different places, but it's going to take some commitment and investment in creating an infrastructure that puts the individual back in the center of where that data comes from, both to drive the creation of new knowledge, but also then to apply that knowledge back to the individuals who are contributing.
100%.
Stuart?
Let's avoid the tech debt death spiral crash on the AI shores, right? I do think the moment is really now, not only in the US, but on a global basis, to get this right? Otherwise, we miss 5 years of the opportunity that AI can provide in healthcare.
Peter, last word.
Just to build on Chris's comment, we have all of the tools and knowledge at our disposal to have technology that would give doctors and patients the ability to say, can you find 500 patients that were just like me? Tell me what happened to them, how did they get better, and how much did it cost? We have the technical means to do that if we can just solve this data architecture issue.
We just need some plumbing. So,
Well said.
thank you, everybody, for joining us today. Thank you, Peter, Chris, Stuart. I hope you all enjoy the rest of your time in Davos.